So the first shock that I'm going to talk about is cardiogenic shock. When we think of cardiogenic shock, we think of pump failure. The most common cause of this is from a myocardial infarction. So what is cardiogenic shock? It's going to be a decreased output due to that myocardial infarction or whatever it is. It can be a dysfunctional valve. Um, and there is presence of hypoxia due to this damage to the heart. Cardiogenic shock is the leading cause of death in acute myocardial infarction. So what I want to talk about most is the myocardial infarction will lead to decreased contractility of the heart. So when the heart has a decrease in contractility, it's not going to be able to pump enough blood. So this can lead to the left ventricle backing up into the left atrium and eventually backing up into the lungs. So what you will see on an x-ray is a lot of congestion around the pulmonary veins and around the heart is congested. So this is not a normal x-ray. So you'll see a lot of fluid built up. The patient will have a productive cough, and some symptoms that you will see is hypotension is very common in pretty much all the shocks. It's going to be a systolic less than 90. From that fluid backup, you will see their jugular veins could be distended. There will be poor perfusion throughout the body. This is due to the blood trying to go to vital organs such as the lungs or heart. So it's going to go away from the skin. Their skin's going to be cold, clammy. So this is a cold shock. The peripheral pulse will be faint. The pulse pressure will be low because the blood pressure will be low, and the patient will usually be tachycardic, as you can imagine, because the heart's trying to compensate for that low blood pressure and that low cardiac output. So some hemodynamic findings and monitoring. A very important thing to look at with cardiogenic shock would be pulmonary capillary wedge pressure. This can assess the back pressure in the heart. So it's going to be greater than 15 millimeters of mercury. And a normal heart that doesn't have that back pressure and all that fluid will be less than 15. And another thing to look at is a cardiac index. With cardiogenic shock, it'll be less than 2.2. And with a normal heart, this assesses the left ventricle and the output of that. So on a normal heart, it will be greater than that. And systolic pressure, we're talking about hypotension. It'll be less than 90 millimeters of mercury. And some monitoring that you can do is Swan-Ganz catheter is very useful. You'll see this, and this will be used to exclude other causes of the shock. So some pharmacologic options. Aspirin can be given to the patient to reduce the likelihood of another MI or even a stroke. Vasopressors will improve cardiac stimulation, and they will really constrict down on those vessels and cause vasoconstriction. What we want in these patients is that because of the low blood pressure. Diuretics can be given. We were talking about pulmonary edema. This can be used to get some of the fluid off of the patient. Dopamine, just like the vasopressors, will cause vasoconstriction and cardiac stimulation. Norepinephrine can be used if the other vasopressors aren't working and if the patient has severe hypotension, which is considered anything below 70 millimeters of mercury. Mechanical ventilation for cardiogenic shock is commonly required. We do know that non-invasive positive pressure ventilation can actually improve the hemodynamics of someone with pulmonary edema. So it will help if you give a patient some Lasix and some of that positive pressure to push that out of the lungs. As far as positive pressure with an actual mechanical ventilator invasively, we do want to watch out. We do want to watch for their hemodynamics because the PEEP can affect that the venous return with the heart, and that's one of my concerns with mechanical ventilation. And an ABG will initially show respiratory alkalosis. This can be because the patient has anxiety and they're breathing fast, they're in pain. And later stages, as the respiratory muscles get tired, we could see respiratory or metabolic acidosis.